Okay, perfect. So the reason why I chose the topic is that, this particular task has appeared in the recent exams, year May 2026. And the sexual assault has been the very favorite topic of RCOG, and it is keep appearing in the exam. At least in one day or two, you will definitely have the topic or the station on this particular sexual assault. It is tested as structured discussion. It is tested as simulated colleague task. It has appeared as a teaching task where your ST1 or ST2 has seen this particular patient in emergency department, and they have done some preliminary, the examination and things like that, and they have come with some diagrams that they want you to go through it, and if there are any corrections and things like that. So that's basically one of the tasks that has been keep appearing, and it has come in this exam as well. Other one is a gang rape, and that has appeared as a structured discussion as well as simulated patient task. And otherwise, alleged history of sexual assault that has been basically assaulted by the boyfriend or the person whom she's well aware of. So these are the common scenarios that is keep appearing in the exam, and it's a very, very important topic you guys must be knowing. All these 4 to 5 variations of the sexual assault you guys must be knowing. So many candidates found this one particular scenario in the recent Part 3 MRCOG exam quite challenging. At first, it looked straightforward, but the real test was hidden in the way the case was framed. Okay, several candidates felt they had answered the obvious parts, yet the examiners were not happy. They were looking for something very, very specific from the candidates. This is exactly many candidates, lost their marks in the exam, particularly on this station. So not because they didn't know anything about sexual assault, but because they missed these important ethical, legal, and professional aspects behind the scenario. So in today's session, we'll break down how to approach such, the gray area stations, and how to understand what exactly the examiner were looking for in this particular scenario, and how to structure your answer safely without jumping into conclusions. Okay, so this is why I have chosen this particular topic. I don't want to take up some easy topic and then just finish it just for the sake of it. All right, so I want one of the volunteer for this particular task. We have only one task. This has to be discussed in detail. So this itself will take more than an hour. So that's why I've kept only one task for today's discussion. So anybody who wants to volunteer, and then it's okay. It's a safe learning environment. Attempt how much ever you know you can. And then after that, yeah, there is always a scope for discussion, isn't it? So who is there? Who wants to volunteer for this particular task? I can see 21 participants. Who wants to volunteer?
I will
Someone?
volunteer.
Who's that?
Fatima.
Fatima. Hi, Fatima. All right.
Let me try. I'm not too sure, but yes.
No, that's fine. That's absolutely fine. Okay. So without wasting any time, we'll just begin the session. So, yeah. So this is your task, and this is the only slide for you to go through. And your 2 minutes starts now. And if possible, please open your camera while presenting, dear. Happy to start, Fatima?
Yes, ma'am. It's difficult for me, but I'll try. Okay. I'm Fatma in the. I'm Dr. Fatma. I'm Fatma in the one of the candidates for the MRCOG Part 3 exam today, and I have a patient today who is brought unconscious, and she has had her history. Has her history of being sexually assaulted, and she's been brought by the police. So on the background, she's unconscious. Her ABCD, ABCD and E assessment has been done, and she's been intubated. And she has also, under the effect of toxicology, under the influence of alcohol and benzodiazepine. Um, and also, there is blood staining noted on the medial aspect of her thigh, but there's no active genital bleeding. And imaging has been done, and there is no significant intracranial bleed. So now I would want to assess whether I would want to take a thorough history of a complete examination, run investigations, and involved the MDT, where I would involve the toxicology forensic department, and involve the police, the SAR, that is Sexual Assault Referral Center, and my consultant, and me. All of the us will be involved in her care, and we will see how to go about, and next how to mm, yeah, how to treat her. Yeah. So the initial
Okay, so
management.
my first question to you is, what would be your initial management in this scenario?
The initial management would be to see whether she is hemodynamically stable, and whether now she is conscious. She was brought unconscious and she was intubated. So I want to see whether, whether there is any involved anesthetist for her vitals. I would want to see whether there is any active bleeding. If there is any active bleeding, I want to take care of that, and involve the my consultant also in her care.
Anything else you want to
Then,
add to your initial
if she is
management?
conscious, yes, I would be very empathetic and sympathetic in this scenario. And once she is conscious, then I would want to take her confidentiality, win her confidentiality, and take a thorough history from her.
Okay.
Yes. Mm.
Anything else you want to add to your initial management?
Uh, um, uh, if she is conscious, ma'am, then I would want to take a thorough exam. I want to take a thorough investigation.
Okay. So what possible causes you're considering in this scenario?
So this could be a case, or this from her history, it looks like this is a case of rape, uh, as she's been brought by the police, and she's under the influence of alcohol and benzodiazepine, and also her clothings have been uh, that from her clothing also we can find out, and also dried blood stains on her body. So having said that, I would want to also I would think about a road traffic accident, or yes, ma'am.
Anything else you want to add?
Mm,
Okay, so would you perform a genital examination while the patient is unconscious, and how would you proceed in this?
uh, uh, Yes, I would want to. I would involve the forensic department in this, and we are not. We will not be taking any decision of examining her. It will be the forensic department decision, and I would involve the SAC also in her care, because she has been brought unconscious, and only after she regains her consciousness, and what level of interference she wants, and what level of confidential at what level she feels confident to tell about herself, it's only then we would escalate the matter.
Okay.
I would involve the forensic department. And yes, if once she is conscious, then I would want to take a thorough history about. I would win her confidentiality, being very sympathetic and in a empathetic way. I would want to ask her who are the men involved. I want to ask her whether she knows those people, and then I want to ask her whether there was any what kind of assault was it, whether it was penetrative, and I would want to document everything in her language, and being very non-judgmental about it. And yes, I would want to take a thorough menstrual history, and would want to give her if I would also, I want to know if she has taken any, she's using any contraceptive, and would want to consider giving her emergency contraception. I would also involve the sexual health department to take along with the forensic department, to involve in taking the genital swabs, and also ruling out other viral infection like HIV, HBS, AG. And I would tell her that these have to be repeated over the time, or where the swabs will be repeated within 3 weeks, and the toxicology, the HIV and HBS after 3 months. I would want to give her the prophylaxis for HIV, and also see the immunity for HBS AG, and give her accelerated vaccine if if not, if she has no antibodies. And also, if because she has some blood, I would also consider tetanus toxoid in her management. And then I would also, yeah, I would, because this is a lot of psychology involved in this, I would want to give her, be very supportive, and also give her, um, or support group where I would involve the SAC and other support group, like refugee and women's care, where I would get her involved. And then I would I would involve the social service, and also the uh, to see that her, I would take a thorough history about how uh, her safety at home before she leaves, and only if she's comfortable I would send her home, but otherwise I would want to make sure that if she would, I would admit her in the hospital. Of course she's now after that I would keep her in the hospital till her environment is safe.
So I'll come back to, since you have answered my fourth question, I will come back and ask you again in question number three. So would you want to say anything about your question number three? Would you want to do any genital examination while the patient is unconscious? If yes, how you are going to do? How would you proceed?
From my knowledge, ma'am, as of all the sexual assault patients are to be examined only by the forensic team, and the sexual assault, the SAC. And if at all we are going to do, or we are going to take we are going to do any examination, it will be only the external, where we are going to mark and draw the diagrams where all the injuries are there. And
Okay, you will have basic evidence kit in the emergency room, isn't it?
yeah,
So
yeah.
don't you think that we are losing the evidence? Do you want to
If
do that?
if she denies going to, because the police is involved, if she denies going to the SAC and forensic department, then I would open the emergency kit and take, I would take her mouth swabs, and the I'll tell her to gargle and take the that's specimen, and I want to take her urine,
Patient is
and also
unconscious.
all the toilet paper. Yeah.
Patient is unconscious. So would you want to do that basic evidence kit which is available in the emergency room or not?
Unconscious, and then if I have to uh, yes, because uh, if I'm going to catheterize her, then I would want to take that sample for urine. But otherwise, I don't know, ma'am. I've never seen this unconscious. I've not got this kind of case.
Okay, your time is up, dear Fatima. Well done, my love. Okay, so what is your reflection?
Anyway, ma'am, I attempted.
Okay, so you knew many things about the sexual assault, so you almost demonstrated your knowledge on the sexual assault. So these are the common pitfalls that happen during the exam as well. The people who have prepared and gone, they told everything about the sexual assault, but the examiners were not happy. Why do you think so? I'll come to your reflection. I'll come to the feedback of yours. You told
Yeah,
everything. You told everything. You told beautifully, you narrated everything about the sexual assault, whatever is given in the talk. Still, I'm not happy. Why?
because this patient is unconscious.
So, did you go in that direction or not? So, everywhere you were like, if the patient is conscious, if everywhere, if patient is hemodynamically stable, everywhere you are like, if she accepts, everywhere, if she denies.
Yes.
So, it was all ifs and buts.
Yeah. Mhm. I've never
The
faced this
scenario is
unconscious.
simple. You don't have to imagine that she is awake. My question to you is simple. She is unconscious. As simple as that. Yeah?
Mm-hmm.
So, do you
Mm-hmm.
think that everything you told holds good now? That was the common pitfalls, right? So everybody
Mm.
spoke everything nicely about the sexual assault, and then the station was demanding something else. So let's hear from the group, and then I'll come to your feedback, okay? But then you
Okay,
did
okay.
amazingly well on the sexual assault topic for sure. Okay, you knew
Thank
everything
you.
very much. Okay, so yes, over to you guys from the group. I want to hear. So what were those common the pitfalls that I was talking about? Anyone who wants to add something?
Ma'am, this patient need to shift to the ICU as her GCS is 6 by 15,
Okay.
and she has
Why do you want to
so
shift her to ICU?
her
GCS is 6
GCS
on 15.
is 6 by 15.
Okay, they have done everything. She has been reviewed by the emergency department. She has been intubated. Okay, they'll do that. Even if she's intubated in the emergency room, that's fine. They will shift
And
her, where she is now. That's not the issue. She has been stable. She has been stabilized. She has been assessed by the emergency department. She has been assessed by the neurosurgical team. She has been intubated. She's hemodynamically stable.
yes, and is there any role as she is under alcohol and benzodiazepine? There is any role for antidote of benzodiazepine and alcohol, benzodiazepine, like naloxone?
Okay, fine. Move on. Then.
And also, there is a role for antibiotics also in the initial management, as there is a uh, blood staining from the medial aspect of our thigh. So, antibiotics for prevention of infection and emergency kit collection can be done because
So you will do emergency kit collection. What is the emergency kit collection? What exactly it is? Can you tell me more about that?
these are usually urine, the clothings,
Urine?
um, urine and the clothings, and any swab.
Mouth
Swab.
rinse. Mm.
Okay. There are some other questions here that can we take a legal advice to take some samples? Okay, I'll come to that. What about legal power of attorney and asking next of kin again? These are the common pitfalls. The students were behind. She was found somewhere on the road and she was found by the passerby somewhere at 3:30 in the morning and we don't know her identity. So what is the question about the next of kin here? We don't know who is she, where she belongs to, who is her family, who is the next of kin. So tangential discussion altogether. So you guys are imagining that if but I'm talking about whatever is there in front of you, you talk about it. Anybody else who wants to add
Ma'am,
anything to this?
ma'am, here the patient is unconscious, so we can't take her consent right now. So
Hmm.
is this, we will arrange kind of a best interest, where we can involve, like police is already involved. So as we have read, without consent, we can't take the evidence collection kit. So,
Okay.
so as per, I think we have to plan a meeting, urgent meeting with emergency consultant and the other experts
Okay. So
regarding.
my next question to you here is that you are saying some MDT approach has to be done to go in the best interest principles.
Mhm,
Okay, partially you're right. So your consultant is not available. So whom do you approach?
mhm. Ma'am, the patient is an emergency, so we can call the emergency consultant, I think. She
Okay.
is.
All right. Yes.
Hospital
Anything
forensic,
else?
hospital
Staff
forensic department.
involving.
Mm-hmm.
And apart from this, ma'am, we have to take a legal advisor. I think also police is already involved. So
Okay.
till the patient is unconscious, we will take a joint meeting regarding the best interest for the patient. What I feel.
Okay. Okay, fine. You were almost there. So I'll come to that. Your best interest meeting, she has lost the capacity to give the consent, your mental capacity acts, what exactly it says. All of that will come to it, whether to do an examination or not. My first question to you, Dr. Fatima, first of all, you did not let me ask any question. You just started. So I'll just give you a quick introduction how to go about a structured discussion. You just enter, okay, smile and greet them. You just tell that, you're so and so, I'm ready for the structured discussion. You don't even have to say that I'm part 3 MRCOG candidate. Everybody knows that you're here for the examination today. So nobody would fall for all those fancy words. So just eliminate it. Don't waste your even 5 seconds, 10 seconds there. Okay, you don't know
Okay.
how many questions you have got. Just say that I'm Deepika. I have read the instructions, ready for the structured discussion. As simple as that. Okay?
Okay.
And after that, please give a pause. Don't read out what is in front of you. And the examiner will be definitely get upset because he's doing two circuits in the morning and the evening. And then everybody is coming and saying the same information which is already given. They get pissed. I don't want you to repeat the information which is given to you. I'm not interested in that. Okay?
Mm. Okay.
Yeah. So first thing is that do not just say what is in front of you. Just wait for an examiner to give you the question in the structured discussion. That is the first thing I want to tell you. And the second thing, the first pitfall you did is that, yeah, that's what you did not ask anything. You did not allow the examiner to ask any questions. The second pitfall is that repeating the information which is already in front of you. Okay. My next question, I had to, interfere and then ask you that what is the initial management of yours? So what you told, I want to know she is hemodynamically stable. I want to know whether she is conscious. I want to know her vitals. I want to know whether she is actively bleeding or not. If she is conscious, then I will be very empathetic and sympathetic to the patient. If she is conscious, then I will take the detailed history. Then what is the point of giving all of these details to you? Correct? She's
Okay.
unconscious. We are in real time. She's unconscious. And they have
Okay.
already given the ABCDE assessment has been completed. GCS score on presentation was 6 over 15. Emergency team has already been involved. Neurosurgical team has been already involved. There is no significant injury on the CT scan. They have ruled out head injury as well. She's hemodynamically stable. They have collected her bloods and urines and they have done the toxicology screen. And they can see some dried blood staining noted over the medical aspects. So all that external examination also they have done. What is the point of you repeating the same information? So this is what most candidates, 90% of the candidates did in the exam as well. Repeating the same information, or I want to know this, I want to know this, I want to know this. The results are in front of you. They have just given you, provided you just went into the emergency room and emergency physician is handing over his notes and saying that this is his findings. Right? Always have that situational awareness, my dear, that do not read out what is in front of you. This holds good for other structure discussions as well. They repeat the same information that I can see hemoglobin is this much, I can see WBC is this much, I can see this. Nobody wants to know. I know that is that much only. I want you to interpret and tell me. Okay, that she is in a shock, she is having thrombocytopenia, she is in sepsis. That is why I have given you those results to interpret and tell me, not to repeat that information. Understood? Okay.
Okay, ma'am.
So now I want to hear from the group that what is your initial management? Anybody? Come on, guys, we have to move forward. There's a lot of things to discuss. Anyone input from anyone?
Involve MDT, ma'am. I don't know.
Okay, go on.
Involve my consultant and then
Consultant is not there. Don't even say that. Consultant is
then
not
my
there.
forensic department of the hospital
Okay.
and
Then
and SARC.
SARC
SARC.
involvement.
Okay. Then anything
Police
else?
is-
You
police is
are
there.
catching. You
Safeguarding.
guys told so much that she is unconscious. She has lost the capacity, mental capacity to consent. That is what you have to put in there.
Court,
Not
ma'am.
saying all of this. You just say that as the patient has already undergone ABCD assessment, she has been intubated, reviewed by the emergency team and neurosurgical team, and she is hemodynamically stable, and police is already involved. That is what it's already given here. Can you see here?
Yes.
Yeah, in the no
Yeah,
relatives
last
of
line,
next one
last
have been
line.
identified and police are now involved. Just
Yes.
acknowledge what is there. Just say that I can see from here that the patient has already been, stabilized. She underwent ABCD assessment. She has been intubated. She has been reviewed by the emergency medicine and neurosurgical teams, and she is hemodynamically stable. Police is already involved. This is already done for the emergency physician. So now my priorities are to ensure the ongoing patient safety, recognizing this as a potential safeguarding concern because she lacks the mental capacity. So I am going to involve my senior team, including the safeguarding. You have to alert adult safeguarding team, SARC, and preserve any potential forensic evidence. SARC itself will do they will only liaise with the forensic team member. So she is a vulnerable adult with query safeguarding concerns. I don't know yet what's going on, whether she has fell off, whether it's a sexual assault, I don't know yet. So there is definitely she is a vulnerable adult with a safeguarding concerns and a possibility of a sexual assault or a drug facilitated assault. So you have to give that interpretation of what is in front of you, not repeating the same information there. Okay, looking at this chart, I can see this has been done. She lacks the mental capacity. So I will alert the senior teams, safeguarding, SARC, preserve the the potential forensic evidence. She is a vulnerable adult with possible safeguarding concerns, possibility of a sexual assault or a drug facilitated assault. I will immediately escalate the case to the adult safeguarding team and document the concerns clearly. This is the first thing. That's the interpretation of your first page. Second, so she lacks the mental capacity because of this reduced consciousness and intubation. So here the Mental Capacity Act would apply. Your mental capacity MCA would come in here. So any decisions made at this stage should be in her best interests. Importantly, next of kin cannot provide any consent for forensic examination on behalf of adult somebody who's lacking the capacity. Anyways, this I have added because somebody else has answered this there. But this doesn't apply because this is an unidentified lady. We don't know what is her identity. So even if you have got a next of kin available, if you get that scenario with a small twist, they cannot give the consent for forensic examination on behalf of adult who is lacking the capacity. Okay, and you have to also acknowledge and tell that my consultant is currently occupied in theater, so I would seek help from consultant covering the acute floor. It could be your emergency medicine consultant who is already involved in the patient's care. Don't say like I will call my consultant, I will tell them it's an emergency, they have to come and things like that. Inform the consultant at the earliest opportunity. But emergency physician is already involved in her care. Just liaise with them and inform your consultant at the earliest available opportunity. Clear, everybody?
Yes, ma'am.
Everybody, everyone.
Yes, ma'am.
Yes, ma'am.
Okay. So here, that is what you have to tell. What has already been done? I can see this has already been done. Don't say, I want to know this, I want to know this, I want to know whether she's conscious or not, I want to know whether she's human or everything is in front of you, dear. So just say that I can see all of that. She's an adult who has lost the consciousness and she's been intubated. So she currently lacks the capacity. So here the Mental Capacity Act would apply. Okay, so here we have to make a decision in her best interest. So I will immediately alert hospital safeguarding team, SARC, and preserve all the forensic evidence. And my consultant is occupied, so I will liaise with the consultant covering the acute floor who is emergency physician. And I will inform my consultant at the earliest opportunity. So they are expecting that you as ST5 who has entered the emergency room, things have been settled, and now what will you do? And people, everybody chase the same things that, oh, once she gains consciousness, I will take the history, and my history would begin with whether she's comfortable, I'll give the privacy, and then I will ask about the incident, what happened, how many assailants were there, where did this happen, whether there was an ejaculation or not, and whether this person is known to you or not. I will ask vaginal penetration, anal penetration, oral penetration, objects used, and whether condoms has been used, whether there was any injuries, and whether she feels safe to go home. All the known dialogues of the sexual assault was told there. Okay, that doesn't work. Here, have that situational awareness. Imagine what's going on, what has been done, and now entering that room, this is what has been settled. What will I do as a ST5? That should be your immediate initial management. Clear, everyone?
Yes, ma'am.
Okay, perfect. So now you will take, so this many candidates answered, and even Fatima also told that you would seek support from the SARC, which is Sexual Assault Referral Center, and the forensic physician urgently for advice regarding further assessment and evidence preservation. So of course, whether to do an examination or not, we'll come to that later. But at least we have to maintain some chain of custody, which is something that we can do, which is what you tell the healthcare staff members to preserve all the potential evidence. So you tell them to, remove. Obviously, the patient is unconscious. Sometimes because it is all soiled and the clothes are untidy, sometimes they remove it and wash it off or clean it. So tell them not to wash, not to clean anything, and maintain that chain of evidence and document all the findings clearly. Then another thing, important patient safety point is that look for any urgent genital injury. So I can see from the notes that it's only the dried blood on the medial aspect of the thighs. There is no active vaginal bleeding. So please highlight this and tell that I would defer unnecessary invasive examination and seek forensic advice before proceeding further. Clear? Fatima, you were kind of confused about it, but you did say that. Okay, I was happy.
And I was
But,
very sure that I should not be doing, that's
yes,
all. But I
yes.
didn't know how to put it. Yeah, ma'am.
Yeah. So I was happy that you told that as far as I am aware, uh, you know, uh, forensic team has to be involved in collecting the evidence. I was happy about it. Okay. So unless she's acutely bleeding and where you have to kind of contain that bleeding, then only
Yeah,
you're
then
acting.
only.
Otherwise,
Okay,
you
ma'am.
are not acting anything, nothing. Okay. You're just do this, cloth collection or, avoiding washing, cleaning and things like that. And then if there is no active bleeding, then you defer unnecessary invasive examination unless we seek advice from the forensic team. Okay, clear, everybody? Okay, so these are the key phrases the examiner was looking for in your opening answer, which is the patient safety is my topmost priority. There is a safeguarding concern here. She is a vulnerable adult who lacks the capacity. So the Mental Capacity Act applies here. So we have to take any decision in best interest principles. Next of kin cannot consent for the forensic examination in an adult who lost the capacity. Escalating to the senior support, since the consultant, your own consultant, is not available, discuss this with emergency department consultant or acute floor consultant. And inform the ONG consultant at the earliest opportunity. Involve the hospital adult safeguarding team, involve SARC and forensic physician. Preserve potential forensic evidence, avoid any unnecessary washing, cleaning, retain clothing, maintain the chain of evidence, document it, and assess for any urgent genital injury, defer invasive examination. These were the buzzwords examiner were looking for. Does it make sense now?
Yeah.
Yeah?
Yes, ma'am.
Others?
Perfect.
Yeah. So, common pitfalls while taking action and how to overcome them. So don't assume that this is definitely a case of sexual assault. Always keep a differential diagnosis, and do not begin, your station by saying, I will start with ABCDE assessment, or you don't say that I will assess the GCS pupils, call anesthetist, stabilize the patient. Don't say I will do all the genital examination and collect the swabs. And don't say that I will open the sexual assault kit, which is there, the basic evidence kit, and take the samples myself. Evidence collection has to be done, by the forensic specialist. And don't say I will wait until my consultant comes out of theater. Don't ask I will try to liaise with police and try to find out who is the husband and next of kin to take the consent for the forensic examination. These are, it's not like every pitfall that the student has done. It's like one or two here and there. Commonly when I spoke to the students, this is what happened. Okay, clear? Yeah. So moving forward, what possible causes would you consider? So this was my next question. So here we have to definitely have a broader, the differentials. Of course, it looks like safeguarding issues, sexual assault. It could be a possible sexual assault or a drug-facilitated sexual assault, because the toxicology screen has come positive for, the benzodiazepines and alcohol. And it could be even deliberate self-harm as well, or intentional overdose. She must have consumed this alcohol and benzodiazepines, and it could be a self-harm as well. Or it could be trauma related, that she told, Fatima told, that it could be a road traffic accident, it could be a physical assault, accidental fall as well. Or it could be gynecological causes, menstruation, very unlikely. It could be a consensual intercourse with minor genital trauma. It could be even early pregnancy complications as well. Okay, but most likely it looks like a possible sexual assault and drug facilitated sexual assault, but keep an eye on other differentials as well. Okay, fine.
Yes, ma'am.
So although the circumstances raise concerns about possible sexual assault, so do not do any premature conclusions, have the differential diagnosis, and then say it in an exam. Okay, that's how the examiner expects you to be, safer clinician as well. Okay, so now the third question by the examiner was, would you perform a genital examination while the patient is unconscious? Again, do not say like, if she regains consciousness, then I will discuss with her. No, stick to the question, listen to the question carefully. They are saying, this is the scenario. Based on that, you please talk. She is unconscious. So just tell, with the confidence, you tell that, no, I would not proceed with the genital examination solely on the suspicion of sexual assault. Is there any urgent clinical indication for an examination? Is there any active vaginal bleeding? Is there any significant genital injury that requires immediate treatment? No. So I can gather from the notes that it's only the dried blood on the medial aspects of thigh, and there's no active vaginal bleeding. So there's no immediate life-threatening vaginal bleeding or anything like that. So I would defer any examination, any invasive examination. I would seek advice from the SARC, forensic physician, regarding the evidence preservation and further assessment. As simple as that. I would defer invasive genital examination until specialist forensic input is obtained, or until the patient regains capacity wherever possible. Clear? So
Yes,
this I
ma'am.
have taken from one of the NHS trust. Okay. So what exactly they have told here, I'll just read it out for you. Patients must have capacity to consent to forensic medical examination. In circumstances in which there is a temporary lack of capacity, say for example, due to alcohol intoxication, it may be more appropriate to defer the examination until the patient has regained capacity. It's worth waiting for a while if we think it is a temporary lack of capacity due to alcohol or benzodiazepines. Rarely, it may be appropriate to undertake the examination without the consent in the patient's best interest. When is that? If you think she's unconscious following a serious assault, you think that she's not going to regain consciousness anytime soon, then yes, you can go ahead and do it in a best interest meeting by the forensic team. So this has to be assessed on a case to case basis. If a patient is having some mental health problems or a learning disability, who do not assume that they lack the capacity, you have to take the measure. So forget about that. That we are not going to discuss now. So here, Archway is basically, it's one of the name. It's the Glasgow related SARC center. So don't get confused. What is Archway? It's basically a SARC. So you understood now. What are the key points here? Is it a temporary lack of capacity due to alcohol or benzodiazepines, or she is going to be unconscious for a very long time following the serious assault? If it is a temporary lack of capacity, you can wait. You can wait. Okay. If you think that she's not going to regain consciousness anytime soon following a serious assault, then you can go in best interest principles. Clear on this. You guys have to say this in the exam. Okay?
Okay.
Yeah. So, the Mental Capacity Act itself does not specifically tell you whether to perform a forensic genital examination. If you go through your Mental Capacity Act TOG, it doesn't say whether to do the forensic genital examination in the suspected sexual assault. You don't even get to talk about the unconscious patient there. It's out of context. It usually comes under the forensic. We have got other I think physician guidelines are there, or SAR guidelines are there. That's where we have taken it from. So it gives only the framework. Whether the patient lacks the mental capacity, yes. So can the decision wait until the capacity returns? Yeah, it all depends on whether it is temporary or a serious assault. If not, then whether we can go and proceed in a best interest meeting. That's all it says. Okay. Okay, so what are they looking is whether you understand the principles, whether you can apply the Mental Capacity Act or not. She lacks the mental capacity. Is she going to regain consciousness anytime soon? If yes, we can defer for a while until she regains the consciousness. If not, if it is like she's going to be unconscious for a longer time due to serious assault, then go in a best interest meeting. This is what they want to understand from the Mental Capacity Act. And they also want to say that next of kin cannot consent for forensic examination and involve the SARC and forensic physician, and you can only do all of this and preserve the evidence and do the documentation and avoid any unnecessary invasive examination. And if capacity is likely to return soon, defer and seek the women's own consent. If prolonged incapacity is anticipated, evidence may be lost. That time involve the forensic team to make best interest decision. I want you guys to remember all of this. Okay? All of you clear?
Yes, ma'am.
Okay. So who decides? So you as a ONG registrar, you're not going to decide this alone. We need an MDT input that you beautifully has put up here, that the decision should involve MDT here. So that involves you, your consultant, SARC, and forensic physician, senior clinician, which is emergency department consultant, acute floor consultant, adult safeguarding team, informing the ONG consultant. Another pitfall you guys, like mistake you guys are doing in the exam, is that you mention everybody here and there, but there is one particular domain which is communication with the colleagues. You have to score that by saying somewhere that the MDT would involve these people: myself, my consultant, SARC, emergency physician, forensic physician, hospital adult safeguarding team. If you only say them together, you will have a high possibility of getting a pass in that particular domain. Mentioning here and there is fine, but somewhere you tell that MDT would comprise of these many members to get that particular domain right. 2 out of 10 marks. I mean, 2 out of 2 marks. Okay. So these are the people who are going to decide. So that has a marks under communication with your colleagues. So the additional considerations, all these people, all these you guys have anyways covered. You know more than me about this particular topic. So urine pregnancy test you mentioned, because there is a 5% chance that she can become pregnant. Emergency contraception you guys mentioned. STI screening and prophylaxis, and HIV risk assessment, post-exposure prophylaxis, accelerated course of hepatitis B vaccination, police involvement, everything you guys told. I'm not going to get into that. So once the patient regains but this should not be your first answer. What everybody did was that this will come only after she gains the consciousness. So before that, you guys have to talk about the ethical considerations, Mental Capacity Act, and what are the obligations that comes in there. So those are the questions, those are the points that you should talk about it. If you talk about it, if you talk only about this emergency contraception and the HIV, hepatitis B, gum center, Yale, the people will, the examiners were really angry, the way you were taking the station towards. Okay, so once the patient regains capacity, of course, your sexual assault is a topic that you guys can do it, of course. So all methods can be discussed with her. Copper IUCD is the most effective option. However, ulipistol and levonorgestrel also can be considered. And copper coil can be inserted up to 5 days after unprotected sexual intercourse, and or 5 days after the earliest estimated ovulation, whichever is later. Ulipistol acetate can be given up to 5 days, and levonorgestrel can be given up to 72 hours, depending upon whether they have got any contraindications or not. And the fourth question was, police are now involved and there is a concern regarding the possible sexual assault. So what would you do next, and how would you document your findings? Again, so when it comes to documentation, what do you want to tell, Fatima?
Documentation, I would say that this is a medical legal document, and it should have the patient's name, NHS number, age, and all the uh, injury which is on the body, the location, the type, the shape, size, whether there is pain, and all that should be documented in the medical language. And if there is a possibility of, if there is an injury, it should be also told, if possible, from a bony prominence, to show that it is this much away from the exact location of it. And it is a document which is a medical legal. So finally, after a complete thorough documentation, you have to even sign off this document.
Okay, perfect. So now the police are involved. So you just ensure that you have involved the SARC people, forensic services have been contacted. And then you would reinforce all the instructions to the healthcare team that they should not watch the patient, and maintain the chain of custody, and arrange a urine pregnancy test. And as far as the documentation is concerned, yes, as you told, the documentation has to be done very clearly, promptly. We have to record only the factual findings, and document findings as soon as possible after the assessment. Not like, okay, I will assess this patient, see everything, again I'll try to call somebody here and there and document it later. Okay, it can affect the way you are going to write it. So always do it as soon as possible after the assessment, and ensure accurate timely documentation as well, and use a body diagram. It's not just the vulva. So exactly, so you get that simulated colleague task of yours, the teaching task, where they would have written the diagram of only vulva. and they would have mentioned all the layman terminology. So there you have to tell them that you have to write a body diagram. It has to be a front body diagram and then back body diagram. You have to, because most of the time, I think in hardly in 10 or 11% you can see the serious injuries that's seen on the genital injuries, and most of the times it's on the body. So you have to mention you have to use the body diagram and document the injuries accurately using the site, size, shape, color, and type of injuries, not mentioning something like a gash, something like a tear. Okay, they should not mention like this. They have to use a proper terminology like a bruise or a contusion or a laceration. An exact size they have to mention, the depth they have to mention if it is a laceration, and which is they have to precisely mention the anatomical location in relation to the fixed bony prominence, as Dr. Fatima said. And even not just the positive findings, Fatima, even the negative findings that has to be mentioned. Say, for example, if hymen is intact, right, you have to mention that hymen is intact. Okay, so even the absence of injuries also has to be mentioned. Both the positive and the negative findings has to be mentioned. And
Okay.
focused external examination findings has to be in a clock face method. That means that 2 o'clock position, 3 o'clock position, 12 o'clock position. So that has to be done in a clock face method. Okay, so that is something, and date and time, and who has done the assessment, who is documenting this, their signature, designation, and who else was present at the time of you. Definitely, there will be a chaperone, there will be other physicians. So, who else was present? So, that has to be written as well. And you would have spoken to the SAR physicians, you would have spoken to the forensic team, you would have spoken to the police, something like that. So, whatever the discussions held, whatever the advice you got, that also has to be documented. All right.
Okay.
So, so reassess her capacity, and once she regains her consciousness, then introduce yourself and explain the events that have occurred so far. Explain that why there were safeguarding concerns, why police was involved, and explain the investigations, the examinations, or any evidence of evidence preservation measures that has been undertaken already, and reasons for doing that. And then you seek informed consent before any further forensic examination or investigations. And she can go, you can offer an option of proceeding with or declining the police involvement, that Fatima told. And SARC, STI screening prophylaxis, HIV risk assessment, post-exposure prophylaxis, Hep B vaccination, emergency contraception, and ongoing psychological support and safeguarding follow-up. All of those points you guys clearly covered here. So do not bring all of these points right in the beginning and upset an examiner. Okay, everybody knows that you really do know about the sexual assault, but take care of the ethical parts and the legal parts initially. So once the patient regains capacity, the focused shift from best interest decision to patient autonomy, because now she regains her consciousness and we can talk to her whether how she wants to go about it. We have to respect her patient's autonomy. We can always obtain an informed consent and go about it. So your role as O and G registrar is that you recognize that she's a vulnerable adult with a safeguarding concerns, alert adult a safeguarding team of the hospital, preserve any forensic evidence and maintain the chain of custody, involve SARC and forensic specialist, and provide the basic care and documentation. Do not independently collect any forensic specimens. Do not undertake any invasive examination without appropriate training. Okay, and you also mentioned about other support group names as well, Fatima, which was really good. So not just the SARC, we have got Rape Crisis England and Wales, we have got Refugee, we have got Safe Lives, we have Survivor Trust, Women's Aid. Okay, remember at least 3 or 4 names, that is more than sufficient. Even ISWA is also there. So that is something that you guys have to remember. So when it comes to the forensic specimen collection, as we have discussed, if she is in a temporary unconsciousness state due to benzodiazepines or alcohol, as far as the guidelines is concerned, it says that we can defer the examination until she regains consciousness. So it all depends on the MDT input. So they will decide whether to go ahead or not. It involves anesthetist, intensivist, it involves your physician, emergency physician, it involves you and your consultant and SARC, forensic team. Everybody will decide whether to go it in a best interest or whether to wait until she regains consciousness. And the type of specimens collected, it depends on the nature of the assault, and it also depends on how much is the time that has elapsed since the time of this thing. So this was not really required for this particular task, just for the completion sake, I have put this. This is applicable for both part 2 and part 3 exams. So if there is a vaginal penetration, then you can collect up to 7 days after the assault. If there is an anal penetration, you can obtain the swabs up to 3 days after the assault. If there has been an oral penetration, then up to 2 days. It is 7, 3, 2 for swabs. Of course, oral penetration, they eat, they drink, they swallow the saliva. Of course, the evidence will not be retained for very, very long time. It's only for 2 days. After that, there's no point in obtaining the oral swabs. Anal is 3 days, and vaginal penetration, luckily you can take up to 7 days of this assault. If you're suspecting any drug facilitated sexual assault, then you can obtain the bloods within 3 days, and urine, luckily, you can obtain up to 14 days as well. So, there has been a confusion again about that what tests to do now and what tests to do later in the follow-up in a gum center. So, of course, the arrangements, everything will happen through the SARC center. They liaise with the gum clinic or the local GP. So they assess for and offer the post-exposure prophylaxis for HIV, pregnancy test if indicated, STI prophylaxis, psychological support, of course, and signpost all the support groups that we have discussed: SARC, Rape Crisis, Survivors Trust, and Independent, Sexual Violence Advisors, which is ISWA. So HIV post-exposure prophylaxis, we know that we want to start as early as possible, which is within 72 hours, and we give it for a month, at least for 4 weeks. So this is for everybody, but this has to be, explained to all women, and they have to accept it, of course. But there are certain high-risk factors where you have to offer them for sure. If they have had any unprotected anal intercourse, which is the highest risk group, or known positive HIV status of the assailant, if there is an exchange of body fluids, or men having sex with men, drug abusers, all these are the risk factors. And who will follow them up? Because once you start the medications, they may have some side effects. They may not be taking these medications. So to check the compliance and everything. So the gum clinic people only will follow them up about this, the Pepsi. And hepatitis B vaccination, it's an isolated course of Hep B vaccine. And this can be given on 0, 1, 3 weeks, or it can be given on 0, 1, 2 months with a booster dose in either of the course. So this can be given up to 6 weeks as well. So if you miss now before she gets discharged, so once she comes for the follow-up in the gum clinic, that time also you can, offer her within 6 weeks of the assault. So what is the follow-up time? So first follow-up will happen at 2 weeks of time. So here, see, we are not taking any swabs immediately after the sexual assault. We generally give some time for the incubation period. So that's why we take the swabs in a gum clinic after 2 weeks of time. And we are not going to do any hepatitis or HIV testing in the beginning, like when she gets admitted following an alleged sexual assault, unless she is very high risk. Otherwise, we repeat the serology in 3 months of time. If we have given her post-exposure prophylaxis, then we do it in 4 months of time. Okay? So that is something. Is everything clear up till now? Any questions from anyone? This is all you guys are already aware from part 2, and you have read it beautifully. So,
I have
yeah,
a doubt.
yes.
What if the patient, if she's actively bleeding and unconscious? So should we give any suturing in that case?
Exactly. You have to control the bleeding wherever she's bleeding from. That time we do it. Of course, there will be a compromise in the DNA collection and things like that. But again, there, the best interest would come into the picture. We have to save her from ongoing bleeding, isn't it? That is life-threatening for her if that's the case.
Okay, ma'am.
Yeah. Yeah. So who are the vulnerable populations where you can get any of these combinations in the exam? So the children, adolescent, who are less than 18 years of age, and individuals with mental health problems, learning disabilities, migrant trafficked women, or individuals with a substance misuse, transgender individual. They're all vulnerable patients. Okay, and under 16 years, it's very, very important to assess the GILIC competence. So involve the hospital, pediatric and safeguarding teams as well, and refer them to the social services. And most of the time, sexual assault happens as a part of domestic violence, unfortunately. Always a perpetrator will be known to them, and they will be at more risk because the perpetrator is known to them. They know where exactly this lady stays and kids stay, all of that. So that time you can even involve the Mrcog as well. It's basically an agency. So, what are the buzzwords worth remembering in these stations is that the GILIC competence. Okay, when you have a child who's less than 16 years of age, child protection social services, if she's, if they are children, and Mrcog referral, multi agents approach, all of that. So pregnancy prevention, we have already discussed. There is a 5% risk of pregnancy. So that's why we always look at, what contraception she's taking, whether she's using the contraception regularly or not, what is the timing of the menstrual cycle, whether the condom was used or not. Based on that, we will assess whether, we have to offer her the emergency contraception or not. So this particular page is applicable if you get a simulated patient task where you take the history of the alleged sexual assault, isn't it? So there it is important. Okay, it's important to know their gynecological history. It's important to ask them when was the last menstrual period. It's not just the last menstrual period. It is important to ask whether they have got a regular cycles or not, because only the ovulation rule applicable that time, and you have to subtract 14 days retrospectively. So that's why regularity of the cycles becomes important. If she says that I'm using combined pills, ask them whether they are taking regularly or not, whether they have missed any pills in the cycle or not. Okay, and depending upon what day of cycle she is in, assess whether the ovulation must have already occurred. Then levonorgestrel or ulipistol acetate cannot be given. In that time, you have to discuss only the copper coil, and depending upon whether she is before day 20 of cycle or not. So all that will come into the picture. You have to do that, mathematics in the history taking when it comes to patient simulated task. Okay, and discuss all the options, and this we have already discussed. So people are a bit confused about SARC. What exactly is SARC? Okay, I want to hear from you guys. What does SARC do?
Sark is a platform where the all the treatment we offer to the patient who had a history of sexual assault, like emergency forensic examination, and also like contraception and these post-exposure prophylaxis follow-up under one roof.
Yeah. So they have got huge responsibility. They have got 24 hours access to the specialist forensic examination. So once you involve the SARC, they literally take care of everything. Okay, it's a gold standard of care for victims of sexual assault in the UK, and it functions as a multi-agency service within the NHS. They try to link NHS, police, and other voluntary sectors here. So so one is that through the SARC, they help in contacting with a forensic physician, and they have the facilities for both police and self referrals, and they also provide immediate medical management as well. They help with emergency contraception, they help with STI prophylaxis, HIV prophylaxis, hepatitis B prophylaxis, all of that. And even they take care of the follow-up as well. They work in close with the GP and the gum clinics, and they give the proper advice to the patients that when they should come back for the follow-ups. Okay, they have to come at 2 weeks for their STI swabs. They have to come at 3 months for their serology testing, and they ensure ongoing support groups who are taking care of her, supporting her, and even the emotional and other psychological counselors also, they provide all these services. Okay, that's very, very important. So so SARC literally does everything. So that's the first body that we have to involve. From there, everything will get escalated. So, as far as the early evidence collection kit, this I have already answered to you guys, because the people were, because they had the habit of doing a simulated patient task of the sexual assault, and where they try to convince a woman that, we don't have to wait for the forensic team. If you agree, we have this basic kit available in the emergency department. We can collect these, the basic minimum things from you. They have that habit of saying it. So they also told us that until the forensic team arrives, I'm going to do this basic, the evidence kit collection. But now, how does this apply to your station? So this patient is unconscious. She's intubated. She is under the influence of alcohol and benzodiazepines, and she has a possible drug facilitated sexual assault. So you must say that I would preserve the evidence, maintain the chain of custody. I would seek urgent advice from SARC regarding the use of early evidence kit, particularly time sensitive samples, such as urine toxicology. If they have not mentioned anything about the urine, just say that you can collect urine toxicology after discussing this with SARC Center. However, full forensic examination, forensic specimen collection would be deferred until the patient regains capacity, unless specialist forensic advice recommends otherwise. That will never happen. This has to be done by somebody who is a specialist, who has been trained in obtaining the forensic evidence collection. So we cannot do, even your consultant ONG, until unless they have been trained in this area, they cannot do as well. Okay, any question from anyone? I'm here to take all the questions. I have finished today's webinar. I hope I have made this quite clear.
Ma'am, I
Yes.
have a question. If the patient wants to maintain the confidentiality and she doesn't want to involve the police, even then we can involve the SARC.
Yeah, SARC, definitely you will involve. Okay, SARC will take care of other things as well. They also try to talk to them. They also try to, understand her beliefs and her fears behind not to involve the police. And they also try to, convince in such a way that if you fail to convince, of course, the other people also will come into, and they try to pitch in there by saying that you don't have to, go and lodge a complaint with the police. All we can do is that collect the evidence as of now and keep it. Okay, because it's a time sensitive evidence. So if you decide, or if you change your mind in the future, you can always use it. So they try to convince her. So you can always involve the SARC. That's not an issue. Because they do other emergency treatment, follow up, psychosexual counselor, support groups, all that they offer, no? So we have to involve them.
Okay, thank you.
Okay, so what is this? Okay. Ma'am, for the person preparing for first time, what are all the guidelines, materials we should read for sexual assault cases to tackle different scenarios? So basically, the sexual assault has appeared in uh, quite in a different scenarios, but they are almost the similar scenarios that are being asked in the exam. This is a new scenario that has appeared. It's just that it's a bit twisted, but it's the same thing. But until unless you prepare for such scenarios in that 10 minutes, I don't think anybody would do it. So I totally understand the situation of the students that day. So one is that I told you a simulated a patient task, somebody with an alleged history of sexual assault. It could be a known perpetrator or an unknown perpetrator, okay? Or it could be a part of the gang rape. So these were the three scenarios that had come in the exam as far as patient simulated task is concerned. And then the other task was teaching task, a simulated colleague task where they have seen the patient and they have come to you asking how to go about this particular patient, because they were almost, the patient was restless, saying that she would go home. So what are the points that you would take care of there? And also she has done some diagram, and you have to, give her the inputs on that particular diagram that she has drawn. And that is one scenario that keeps appearing in the exam. And the third one is a structured discussion where a very young girl who has been sexually alleged, with a history of alleged sexual assault. Okay, a young girl who's less than 16 years. I think it's even younger, like 8 or 10 years old. Okay, there, how do you go? How do you go about this particular patient? So these are the common scenarios that are being tested in the exam. Yes. Okay, any question from anyone? Any question? No? Not related to this particular task. Any question from any other topic if you want to ask? I know you guys are already well aware of this sexual assault case. It's just that those ethical considerations, according to the Mental Capacity Act, how we have to go about it, especially in an unconscious patient who is intubated. We don't know when she's going to regain the consciousness. We don't know whether it's a serious assault or what. So only that was the only difference to this particular task I wanted to discuss. So if you have got any questions even later, just ask in the group. We can just discuss over there as well. Any questions? Yeah, I'll try to upload it on the YouTube. Supposedly, we were supposed to do it on the YouTube today so that it would have been available on the live recordings for you guys to go through. But otherwise, I will upload this today's webinar. Okay, yeah. So if anybody has not joined our elite groups on the Telegram and WhatsApp, please do join. And we have been conducting the webinars quite often, almost on every Sunday we'll be there, 5 o'clock UK time. And also we are doing the recall sessions in the Telegram group as well. So if anybody who wants to join the groups, please join and just let us know. Okay. Take care, everybody. All the very best. Keep practicing. Any questions, put it in WhatsApp group or a Telegram group. We are more than happy to answer your queries. Take care.
Thank you so much, ma'am. Thank you so much.
Thank you, guys.
Thank
Bye-bye.
you. Thank you so much.